If your doctor looked at your blood pressure reading at your last appointment, glanced up from the chart, and said the words, "Looks fine for your age," I need you to stop and really think about what that sentence actually meant. What number were they looking at? What standard were they using? And here is the question nobody in that exam room ever seems to ask out loud. Fine for your age compared to what? Because here is something that is happening in doctors' offices across this country right now, in cities like Houston, in clinics across Ohio and Florida and Arizona, every single day. Seniors over 60 are being told completely different things about blood pressure by completely different physicians. One doctor says, your target is 130. Another says 140 is acceptable. A third says anything under 150 is fine after 65. And every single one of them believes they are giving you accurate, up-to-date guidance. They are not all wrong, but they are not all right either. And that confusion, that a genuine system-wide disagreement about what number you should actually be aiming for, is costing people their health in ways that are not being openly discussed. I am Dr. Michael Paint, and if you're new here, please subscribe to this channel right now so you never miss the guidance that could change your life. Today, I'm going to give you the real truth about blood pressure and seniors. Not the version that gets simplified into a pamphlet and handed to you after a 15-minute appointment. The full picture. What the numbers mean, why seniors face a completely different challenge than younger adults, what the actual research says about the ideal target, what happens when your pressure goes too high, and what happens, this is the part nobody warns you about, when it goes too low. By the time this video ends, you will understand your blood pressure in a way most people never do, and that understanding is not just interesting, it is protective. Let's start at the foundation, because I find that even people who have been monitoring their blood pressure for 20 years have never been given a clear explanation of what those two numbers genuinely represent. And without that foundation, the rest of this conversation will not land the way it needs to. Every time you wrap that cuff around your arm and it tightens, it is measuring two completely separate pressures that exist inside your arteries. The first number, the top number, called systolic pressure, measures the force your blood exerts against your artery walls at the exact moment your heart contracts and pushes blood out. Every single heartbeat, your arteries receive that pressure wave. The second number, the bottom number, called diastolic pressure, measures the pressure that remains inside your arteries in the resting moment between beats when your heart is refilling. So when your reading says 135/82, that means your arteries are absorbing a peak pressure force of 135 millimeters of mercury every time your heart beats, and a baseline resting pressure of 82 between beats. Both numbers matter. And as I am going to explain, in seniors specifically, the relationship between those two numbers tells a story that is just as important as either number on its own. Normal blood pressure for a healthy adult is considered less than 120/80. That is the benchmark. Elevated blood pressure sits between 120 and 129 on the top number. Stage 1 hypertension begins at 130/80. Stage 2 hypertension begins at 140/90. And a hypertensive crisis, the situation that requires emergency attention, starts at readings above 180/120. Now here is where it starts to get specifically relevant to you. Because if you are over 60, your arteries are responding to blood pressure differently than they did when you were 45. And that difference changes everything. Inside every artery in your body, the vessel wall contains layers of smooth muscle tissue and elastic fibers. When you are younger, those fibers behave like rubber bands. When your heart beats and sends that pressure wave through, the artery walls stretch slightly to absorb the force, then recoil to push blood forward. It is a remarkably efficient mechanical system. But here is what decades of living, combined with chronic low-grade inflammation, exposure to processed foods, and the natural aging process itself, does to those elastic fibers over time. They stiffen. The technical term is arterial calcification, but the practical meaning is straightforward. Your artery walls gradually lose their ability to stretch and recoil the way they once did. They become more rigid, more like pipes than elastic tubes. And when that happens, your heart has to work significantly harder to push blood through those stiffer vessels. The result is almost always a rise in the top number, the systolic reading, while the bottom number may remain the same or even begin to drop. This produces a pattern called isolated systolic hypertension, which is by far the most common form of high blood pressure in Americans over 65. your systolic reading climbs to 138, 145, 150, while your diastolic number stays at 75 or 78. Your doctor looks at the bottom number and tells you the diastolic looks fine, but the top number is working against your arteries every single day. More than 70% of American seniors have high blood pressure, and the majority of those cases fit exactly this pattern of isolated systolic hypertension driven by arterial stiffening. This is not a fringe medical issue. This is the dominant cardiovascular reality of aging in America, and understanding it is the first step toward knowing what number you are actually aiming for. The real debate: what number should seniors target? Now we arrive at the heart of this video, because this is where the medical world has been genuinely divided, sometimes loudly, for the past decade, and you deserve to hear both sides of this debate clearly. For a long time, the conventional wisdom in American medicine was that blood pressure naturally rises with age, and therefore seniors should be held to a somewhat looser standard. The thinking was straightforward. Older adults are more sensitive to the side effects of aggressive blood pressure treatment. Their bodies need a slightly higher pressure to push blood through stiffened arteries efficiently, particularly to the brain. Treating too aggressively creates new dangers. So for years, many physicians treated patients over 65 with a target of systolic blood pressure below 150, sometimes even below 160. Just get them under 150 and consider the job done. Then, in 2015, the results from a major national study funded by the National Institutes of Health changed the conversation completely. That study, known as the SPRINT trial, enrolled over 9,000 high-risk American adults, most of them older, and asked a direct question: what happens when we target a systolic blood pressure of less than 120 compared to the standard target of less than 140? The results were striking enough that the study was actually stopped early before its scheduled end date, because the benefit of intensive treatment was already so clear that researchers felt it would be ethically wrong to continue withholding it from the standard treatment group. Adults in the intensive treatment group, targeting systolic below 120, had significantly lower rates of cardiovascular events, lower rates of heart failure, and a 27% reduction in risk of death compared to those in the standard group. Those numbers shook the medical establishment, and in the years that followed, the American Heart Association and the American College of Cardiology updated their guidelines to reflect a new standard. For most adults, including older adults living in the community and managing their own lives, the target became systolic below 130 over diastolic below 80. The 2025 AHA and ACC guidelines went further in nuance, moving to what is called a risk-based approach. Rather than automatically medicating every senior with a systolic reading above 130, the new framework asks your doctor to assess your overall 10-year cardiovascular risk before deciding whether medication is the right next step for stage 1 hypertension. If your systolic reading is between 130 and 139, and your 10-year cardiovascular risk is relatively low, lifestyle changes come first. Reassess in 3 to 6 months. If your reading is at or above 140 over 90, treatment begins regardless of risk calculation. The goal for all adults, including those over 65, is below 130 over 80, with important individualization for people who are frail, living in care facilities, or managing serious comorbidities. This is a more sophisticated standard than the old "just keep it under 150" thinking, but it is also more demanding, and it requires your doctor to actually calculate your cardiovascular risk rather than simply glancing at your chart and making a quick judgment call. If your physician has not recently discussed your 10-year cardiovascular risk with you, that is a conversation worth initiating. The danger nobody is warning you about on the other side. Here is where the story becomes urgent in a direction most seniors never anticipate, because everything I have described so far discusses the risks of blood pressure being too high, and those risks are real, documented, and serious. But there is an equally real danger on the other end of the scale, and it is one that medical professionals genuinely do not discuss loudly enough with older patients. When blood pressure in seniors goes too low, either because of medication, dehydration, or simply the physiology of aging, that the consequences can be just as devastating as those caused by high blood pressure, and in some cases they arrive faster. The most immediate risk is orthostatic hypotension. This is the condition where your blood pressure drops suddenly the moment you stand up from a sitting or lying position. You know this experience. You stand up from your recliner after watching the evening news, and for 2 or 3 seconds, the room tilts. The edges of your vision go dark, and you have to grab the arm of the chair to steady yourself. That sensation is not a quirk of aging. That is your blood pressure dropping faster than your cardiovascular system can compensate for. For Americans over 65, this kind of sudden postural pressure drop is directly responsible for a devastating number of falls. A fractured hip from a fall, caused by a dizzy spell from blood pressure that dropped too fast when standing, that is not a minor medical event. In adults over 70, a hip fracture carries a 1-year mortality rate that rivals many cancers. The fall itself becomes the medical emergency. And now here is something the research has begun to reveal that should make every senior in this country pay attention. Orthostatic hypotension, blood pressure that drops when you stand, has been linked in multiple studies to a significantly elevated risk of cognitive decline and dementia. When the brain is repeatedly deprived of adequate blood flow in those moments of standing, the cumulative effect on brain tissue over months and years is measurable. Scientists at Johns Hopkins and the Framingham Heart Study both produced data showing this connection. Dizziness when you stand is not just a nuisance. It is a signal from your brain that it is not receiving what it needs. There is also evidence, including from researchers at the Albert Einstein College of Medicine in New York, showing that persistent low diastolic blood pressure in seniors over 75 is associated with higher rates of dementia. The brain requires a consistent, adequate blood supply to function and repair itself. When that supply is chronically insufficient, the consequences accumulate in ways that blood tests and basic office visits do not catch until the damage is already significant. And for your kidneys, the story is equally sobering. Kidney function in older adults is highly dependent on adequate blood pressure to maintain filtration rates. When systolic blood pressure in seniors falls below 110 or 115 consistently, kidney function can begin to decline measurably. You may not feel it. Your routine blood work may not flag it immediately, but the decline is underway. So here is the picture I want you to hold in your mind. Your optimal blood pressure is not simply as low as possible. It is a specific range, a window, where your brain, heart, kidneys, and arteries all receive adequate flow while not being subjected to excess mechanical pressure. Getting the number under 130/80 is the goal for most seniors, but crashing it below 110 or 100 through aggressive medication or inadequate hydration creates a different set of dangers that deserve equal respect. Third number nobody is looking at. There's a third number embedded in every blood pressure reading that most Americans over 60 have never been told to pay attention to. And that number may be one of the most important cardiovascular signals your body produces. It is called pulse pressure, and you can calculate it yourself right now. Take your systolic number and subtract your diastolic number. If your reading is 145/72, your pulse pressure is 73. A healthy pulse pressure for an adult is generally considered to fall between 40 and 60. When pulse pressure climbs above 60 in a senior, it is a documented independent predictor of cardiovascular risk, specifically heart failure, stroke, and cardiovascular mortality, over and above what systolic and diastolic readings reveal on their own. What does an elevated pulse pressure actually mean physiologically? It means your arteries have lost significant elastic flexibility. Remember the rubber band analogy I described earlier. When your arteries stretch and recoil efficiently, the pressure wave your heart generates gets absorbed and distributed smoothly. The difference between systolic and diastolic stays manageable, but when those arterial walls stiffen, the pressure wave is transmitted violently rather than absorbed. The systolic number spikes higher with each beat, while the diastolic number may actually fall as the heart has less and less resting resistance to push against. The gap between those two numbers, your pulse pressure, widens. A wide pulse pressure in a senior is essentially an arterial health report card, and it says that the vessel walls are losing their flexibility at a rate that is creating measurable mechanical stress on the heart, the brain, and the kidneys with every single beat. Researchers at the American Heart Association have demonstrated that a pulse pressure above 60 is an independent risk factor for congestive heart failure in elderly populations. Not a minor finding, a significant independent predictor. If your doctor has never mentioned your pulse pressure, look at your most recent reading yourself. Subtract the bottom number from the top. If that number is above 60 and consistently climbing, bring it to your physician's attention directly. It is the number hiding in plain sight inside every reading you have ever taken. White coat hypertension. When your reading lies to your doctor. Seit Prites Damaiter Sameinsaint. There is something else I need to address, because for seniors in America, this issue creates real diagnostic confusion and leads to real unnecessary medication. It is called white coat hypertension, and it affects a significant portion of older adults in ways that are dramatically underappreciated. Here is what happens. You sit down in an exam room at your doctor's office in Cleveland, or Denver, or Tampa. The nurse comes in, wraps the cuff around your arm, and takes the reading. Your blood pressure registers 148/88. Your doctor notes this, discusses treatment options, and may adjust your medication. But here is the thing. Your blood pressure at home, sitting comfortably in your own living room, consistently reads 118/74. Your body, in response to the clinical environment, the unfamiliar setting, the underlying anticipation of a medical judgment, releases a stress hormone response that temporarily elevates your blood pressure, not a small elevation. In some older adults, the white coat effect raises systolic readings by 20, 25, even 30 points. And because most doctors take only one or two office readings before making treatment decisions, that temporary anxiety-driven spike becomes the basis for your blood pressure management plan. The Harvard Medical School and the Mayo Clinic have both published on this extensively. Research consistently shows that white coat hypertension in seniors can result in overprescription of blood pressure medication, pushing what are actually normal home readings into dangerously low territory. Your doctor treats a 148, but your actual blood pressure is 118. With the medication designed to push 148 lower, your actual home pressure becomes 98. And you start feeling dizzy every time you stand up. This is why home monitoring is not a supplemental nice to have for seniors. It is clinically essential. Taking your blood pressure at home in the morning and in the evening over a period of 7 to 10 days and bringing that log to your physician creates an entirely different and far more accurate picture of your true vascular status than the handful of readings taken in a clinical setting. The American Heart Association recommends a validated automatic upper arm cuff monitor, not a wrist device, for home readings, and it recommends sitting quietly for 5 minutes before measuring, taking 2 readings 1 minute apart, and recording both. That record, over a week or two, tells your doctor something far more truthful about your cardiovascular reality than a single office visit number ever could. The most dangerous window in your day, and most seniors don't know it exists. There is a specific period in every day that research has identified as the most dangerous window for cardiovascular events in seniors, and the vast majority of Americans over 60 have no idea it exists, let alone that it is measurable and manageable. It is the first 1 to 2 hours after you wake up in the morning. Here is what is happening inside your cardiovascular system during that window. As you transition from sleep into wakefulness, your body releases a surge of cortisol and adrenaline as part of the normal morning arousal response. Those hormones do several things simultaneously. They raise your heart rate, they increase the contractile force of your heart, and they constrict your peripheral blood vessels, driving your blood pressure sharply upward within minutes of waking. This morning blood pressure surge is normal in modest amounts. But in seniors with existing hypertension or arterial stiffness, that surge can be dramatic, producing a rapid spike of 20, 30, even 40 millimeters of mercury in the systolic reading in a matter of minutes. Researchers studying elderly hypertensive patients in the United States found that the magnitude of this morning surge is an independent predictor of stroke, even after accounting for average blood pressure over the rest of the day. The highest rate of heart attacks, strokes, and sudden cardiac events in the general American population occurs between 6 in the morning and noon. This is not coincidence. It is the morning blood pressure surge intersecting with already compromised arteriobiology in aging vessels that have lost their flexibility. There are practical things you can do about this. If you take blood pressure medication, discuss with your physician whether any portion of your dose should be taken in the evening rather than exclusively in the morning. Some research supports that evening dosing provides better overnight and early morning protection. Do not spring out of bed the moment you wake up. Sit at the edge of the mattress for 60 to 90 seconds before standing. Let your cardiovascular system adjust. Hydrate first thing. Your blood is more viscous in the morning after hours without fluid intake, and dehydration amplifies the morning surge. These are not complicated interventions. They are low-cost, zero-risk modifications that directly address one of the most dangerous physiological moments in a senior's day. The nitric oxide factor, why your arteries lose their flexibility and what to do about it. Everything I have described in this video, the arterial stiffening, the rising systolic pressure, the widening pulse pressure, the morning surge, all of it connects back to a single biological compound that most people have never heard of, but whose decline drives nearly every aspect of vascular aging. That compound is nitric oxide, and I want you to understand what it does, because this understanding changes the way you think about your daily choices. Inside the inner lining of every artery in your body, that thin living layer called the endothelium, specialized cells produce nitric oxide continuously throughout the day. Nitric oxide is the chemical signal that tells your arterial smooth muscle tissue to relax and allow the vessel to dilate and open wide. When nitric oxide production is robust and consistent, your arteries respond fluidly to your heart's demands. They open when blood flow needs to increase. They recoil smoothly after each pressure wave. Your systolic number stays lower because the arteries are absorbing and distributing pressure efficiently. But here is what happens over decades of chronic inflammation, processed food intake, sedentary behavior, and the natural decline of endothelial enzyme activity with age. Nitric oxide production falls. The signal to relax becomes weaker. Arteries respond less readily. They stiffen progressively. And as they stiffen, the systolic number rises, the pulse pressure widens, and every single one of the cardiovascular risks I have described in this video becomes more probable. Regular aerobic walking, not marathon training, but consistent moderate walking, has been shown in studies from the American Heart Association to partially restore age-related declines in nitric oxide availability. Even 30 minutes of brisk walking 5 days a week produces measurable improvements in endothelial function in older adults. This is not a small finding. This is one of the most powerful vascular interventions available to a person over 60, and it requires no prescription. Deep breathing exercises, specifically slow rhythmic breathing at about 6 breath cycles per minute, have been shown in multiple clinical trials to produce meaningful reductions in systolic blood pressure through a mechanism that includes improved nitric oxide release and reduced nervous system activation. A 2023 study published in the Journal of the American Heart Association found that mindfulness practice, which incorporates this kind of deliberate slow breathing, produced significantly lower systolic blood pressure readings 6 months later in adults who practiced it consistently compared to those who did not. 6 months of breathing differently produced a measurable result on a blood pressure cuff. What you eat is directly modifying your blood pressure every single day. The most extensively researched dietary approach to blood pressure management in the United States is a framework called the DASH diet, Dietary Approaches to Stop Hypertension. And I want to tell you what the research actually shows, because most seniors have heard the name but never understood the mechanism. The DASH framework was developed specifically in the context of American eating habits, tested in American populations, and produces results that are genuinely remarkable. Studies have shown that consistent adherence to DASH principles lowers systolic blood pressure by 10 to 11 points on average. That is comparable to the effect of many single blood pressure medications, achieved without a prescription, without a copay, and without side effects. The mechanism works through several simultaneous pathways. High potassium intake from foods like sweet potatoes, bananas, spinach, and avocados directly counteracts the blood vessel constricting effects of sodium, allowing arteries to relax and lowering systolic pressure. Magnesium, found in leafy greens, legumes, and whole grains, supports the smooth muscle relaxation of artery walls and improves the endothelial responsiveness I described earlier. Calcium from low-fat dairy and leafy greens plays a role in arterial contractility regulation, and the broad anti-inflammatory effect of a diet rich in fruits, vegetables, and whole grains directly reduces the chronic vascular inflammation that drives arterial stiffening over time. Sodium is the other side of this. The average American consumes roughly 3,400 milligrams of sodium per day. The DASH framework targets 1,500 to 2,300 milligrams. That reduction alone, without any other dietary change, produces consistent, measurable blood pressure reductions in seniors, and the source of the excess sodium is almost never the salt shaker on your dinner table. It is packaged foods, canned soups, deli meats, bread, and restaurant meals, where sodium levels are invisible unless you are reading labels, specifically looking for them. Reducing sodium, increasing potassium, and eating a diet centered on whole foods rather than processed ones is not a vague wellness aspiration. It is a specific, documented, clinically effective blood pressure intervention that works in your arteries every single day, meal by meal. The stress factor and why your emotional life is written into your blood pressure. There is one more dimension of blood pressure in seniors that deserves a direct conversation because it is consistently underweighted in clinical settings and overexperienced in daily life. Acute stress raises blood pressure temporarily. That is well established. Your body releases adrenaline and cortisol in response to a stressful situation. Those hormones constrict your blood vessels and accelerate your heart rate, and your blood pressure rises for the duration of the stress response. When the stressor passes, pressure comes back down. But here is what chronic unresolved stress does that temporary stress does not. It keeps the body's stress hormone system activated at a low background level for days, weeks, and months. It sustains a mild but continuous degree of vascular constriction. It disrupts sleep, which is its own independent blood pressure risk factor. And it drives behaviors, poor food choices, less physical activity, social withdrawal, that compound the vascular damage through additional pathways. Research published in the Journal of the American Heart Association showed that brief bouts of anger produced measurable impairment in blood vessel function in healthy adults, not chronic disease level changes, functional impairment from a single episode of acute anger. Now, multiply that by the number of daily frustrations, losses, anxieties, and unresolved stresses in the life of a senior navigating health issues, financial concerns, family challenges, and an increasingly fast-moving world. The cardiovascular cost of sustained emotional stress is not metaphorical. It is biological, measurable, and direct.